Hi, everybody. It's Dr. Sloan. We're going to talk about pharmacokinetics and pharmacodynamics. Okay, so these are some big words, pharmacokinetics and pharmacodynamics, but really what we want you to do is we want you to know what they mean so that you understand when people talk about these terms, what they're talking about. So let's just back up a little bit. So pharmacokinetics is what the body does with the drug. Okay, so when we take a pill or we take a medication and it goes into our mouth, all the things that happen to it to make it work and be available to our tissues or the bacteria in our bodies or whatever, that's all pharmacokinetics. Okay, and pharmaco means medicine and kinetics means movement or motion. So the study of drug movement throughout the body is kind of the way to think about this. And there's four key things that happen in terms of pharmacokinetics, and you need to know these. And we're going to talk about some specifics related to them. But the best way to remember them is this acronym of ADME. Also, ADME is the order in which these pharmacokinetics occur, right? So absorption, distribution, metabolism, excretion. And again, remember, this is what the body does to drug. So we're going to go and talk about the first one. So absorption. So when we take a medication, if it doesn't get absorbed through our GI tract, then it's just going to get passed out through basically our stool, right? Our feces. And that can happen. And in fact, a good example of this is someone who's on birth control pills. Maybe they have a diarrhea illness, and all of a sudden the birth control pill isn't being absorbed the way it's supposed to be, and it passes out the body, and it doesn't have its intended effect of doing things with hormones that end up making it so that you can't get pregnant. So just an example of that. So absorption is the movement of a substance from the site of administration across body membranes to circulating fluids. Okay, so think about IV medications, things to get in your IV. They take effect really quickly. And that's because you're bypassing the whole GI system and you're putting them right into the bloodstream. So absorption also really determines how long before a drug takes effect. You take a medication and it doesn't work immediately, right? When you take Tylenol for a headache, you don't all of a sudden just, your headache's gone the minute you swallow it. No, it's because it takes time to be absorbed and to make its way into body membranes and fluids and into cells. And how things are absorbed depends on the size of the drug molecule, its actual molecular structure. Think back to chemistry. What kind of form of medication? So again, oral medications often take 30 minutes to an hour to work, whereas IV medications are almost instantaneous. So how long is it going to take? And a liquid is probably absorbed faster than a pill because a liquid is already broken down, whereas a pill has to dissolve. And then are things lipid soluble? Lipids, if you remember, are a big part of the cell membrane. They're all around, they surround a lot of our cells. And so if you have something that's lipid soluble, it tends to move across membranes faster. And then we have to think about other things that people are taking as well. Other drugs or other foods can influence absorption. So we may need to be careful about that. Like some medications need to be taken with food. Some medications need to be taken on an empty stomach. Dietary supplements can influence absorption. So this is why we want to be really careful about assessing from our patients without judgment, what they're taking. And one of the things that you should be asking too now is, are people using cannabis? Because that is legal and a lot of people are using it, and it is a form of a medication as well. Let's see, bowel conditions. I already gave you a great example of that. And then if you're a visual or auditory learner, you should watch this little 6-minute video. It gets a little complicated, but just if it's helpful to you. I personally am definitely a visual learner. Okay, so distribution. Think about like all of the big trucks that come and go into the Amazon processing center, get loaded up with boxes, and then all those little boxes go out and they get delivered to all these different homes, right? So it's the same idea here, and that's the D in ADME is distribution. So it's the transport of pharmacologic agents throughout the body. And that has to do with a lot of things like blood flow. How much blood flow comes to the target organ or body part? If it's bone, we do have vessels in our bones, but not a lot, right? It's not a highly vascular thing. So it's going to be a little bit harder. And then, as I said before, lipid soluble drugs, which tend to be more easily distributed than water soluble. Some tissues can actually store drugs, fat or skin, and so based on the kind of drug it is, you may actually, your patient may actually have like an odor from a medication as it kind of off gases out the skin. Not a lot of those, but. And then the blood-brain barrier, and we're going to talk about this, the BBB. You learned about this in anatomy and physiology, and the blood-brain barrier is this set of cells that surround the brain and the spinal cord, and they have very, very, very tight connections, those cells. So it makes it very difficult for things to pass across the blood-brain barrier. Now, some things pass very easily because of the way they're transported. Some things really have a hard time. So, for instance, sedatives, anti-anxiety medications tend to pass really easily. They affect the central nervous system, and that's why they affect the central nervous system, because they're able to get in. Chemotherapies and things like that have a much more difficult time. So if you think about treating like the brain for a tumor or something like that, it's harder, even a brain infection. And the purpose of having a tight BBB is to keep bacteria and other toxins out of the brain and the spinal cord, because once those are affected, we know that affects the entire person, the entire body, right? So again, another resource if you want to look at that. Okay, the M in pharmacokinetics is metabolism. This is the big one, guys. You really need to know this. Metabolism of meds, also known as biotransformation. So it's the changing of the medication to a form that's more easily excreted by the liver. So the liver, you need to know this, the liver is the primary organ for metabolism of drugs. Think about that. If the liver is the primary organ for metabolism of drugs and nutrients and a lot of other things, if the liver's not working well, then we may have issues, okay? And then we also have enzymes in the liver that sometimes activate or inactivate drugs as well. And we'll talk a little bit more about that. Or the liver could biotransform medication from an inactive form to a much more active form. So we have to be careful about that. And one of the things that affects liver enzymes is grapefruit juice. And we talked about this a little bit, that we have to be careful because these things are all interrelated. So drink grapefruit juice, that changes the enzymes in your liver, which then ends up causing maybe metabolism problems. And then the last thing that you need to know is something called the first pass effect. So when drugs are let's just say this is related to oral medication, all right? That when you take a pill and it goes down into your stomach and it goes into your small intestine and it gets absorbed across the small intestine and it goes into the hepatic vasculature and into the liver, the liver right there might just totally knock it out of effectiveness. And so now we have something that doesn't work orally. It has to be given IV. So you'll see things that say large first pass effect, give IV, or give IM, or give sub-Q, or some other way other than enteral, right? Okay. And last but not least, we have excretion. So if the liver is the organ of metabolism, the kidney is the organ of excretion. And it's important to know how drugs are going to get out. We just think, well, of course, we're going to either poop them out or pee them out. Well, yes, that's true. But because the kidney is the primary organ for excretion, then we have to think about, again, people with kidney issues. It's not the only organ for excretion, but it is the primary organ. And excretion really determines the concentration of drugs. Think about it. If I take a medication, let's say I take some medication for pain, and that medication is excreted through the kidney, but I have really poor kidney function. My kidneys are not working. If I can't excrete that drug, am I going to have more of the effect of the drug or less? I'm going to have more because the drug can't get out. And so it sticks around longer and has its effect longer. Okay. The other organs that play a role is like the lungs. I know that sounds really strange, but when I was doing bone marrow transplants a long time ago, before you guys were ever born, bone marrow that is donated from one person to another sometimes was frozen, and or the patient used their own bone marrow and it was frozen, and in order to freeze it, you had to put this preservative in called DMSO. And I think this is still used, to be honest, and it protects the cells from, so that they don't lyse during freezing. But when you defrost that marrow and you get it ready for infusion into the patient, and it starts infusing into the patient, the drug itself is metabolized and excreted. It's metabolized through the liver, but it's excreted through the skin and the lungs. This particular chemical, this particular preservative. And so you could just smell it. You could smell it everywhere on the floor. You could smell it. Like I'd get off the elevator and I'd be like, oh, somebody got a transplant today, because you could smell the DMSO. Sometimes you're excreting drugs through bile or glands. There are some, again, chemotherapies that are given that are excreted through the glands, and patients need to take multiple showers a day in order to avoid skin toxicity. So again, if someone has reduced kidney function, how will that affect excretion? Will it increase it or decrease it? Well, if the kidneys aren't working so good, and the kidney is the primary organ responsible for excretion, I would say that it's going to decrease excretion, which means it's going to increase the effect of the drug. Loading doses versus maintenance doses. A loading dose is, sometimes you'll hear this in a med, like give a loading dose and then begin, and it's this certain amount, and then give, that all the doses after that are at this other amount, which is usually less. A loading dose is sort of like helping a patient kind of get up to speed quickly, get their blood levels of the drug high quicker. So usually it's 1 or 2 times the normal dose, and quickly increases blood levels, and it's to help us get to a therapeutic level. And we're going to talk about this a little bit more in the next slide. And a maintenance dose is kind of, once we've gotten up to that therapeutic level, how do we keep it there in terms of drug levels in the body? Okay. All right, so therapeutic range. Therapeutic range is kind of what we talked about a little bit in class, sometimes called therapeutic index. We'll talk about that. So therapeutic range means, kind of where in terms of plasma concentration of the drug, how much drug in your plasma do you have at any one point in time? And if you have too much, right, you can go up here into this adverse area, this pink area where it's dangerous. But if you don't have enough and you're down here, you're subtherapeutic and you're not giving the patient the medication, enough of the medication they need, right? They're not getting enough of it. So there's a therapeutic window. And this therapeutic window is the space between kind of the desired response and an adverse response, or between toxicity and being subtherapeutic. How long the blood stays in this range is considered its duration of action. And a duration of action determines how often we give medications, right? We don't take Tylenol every hour because Tylenol works for about 4 hours, sometimes 6 hours. So when we take Tylenol doses or we see doses, it'll say, Tylenol, 500 milligrams, every 4 to 6 hours is needed. That's because of this duration of action. Yeah, so we'll talk more about therapeutic range as we talk about specific medications, so that you can see what I mean here. And then pharmacokinetics. So pharmacokinetics, again, this is how what the body does with the drug. You have this thing called half-life, and half-life is the length of time required for plasma concentration of the drug to decrease by 1/2 after administration. Don't worry about half-life and knowing the exact definition, but I do want you to kind of understand it enough to know how it affects, drugs. So the other thing is, how does renal or hepatic disease, right? Remember, this is the liver, hepatic, and renal is kidney. So how do those affect half-life? If your liver can't metabolize or your kidneys can't excrete, something to think about. So half-life, right? It determines, again, the drug's duration of action. It's related to that graph that I showed you about the duration of effect, how long it's there. The longer the half-life, the longer it takes to get rid of the drug. Okay, and it determines how often drugs are given to the patients. So the half-life is what determines its duration of action, which is why, right, like Tylenol, again, has a half-life of probably, 4 hours-ish or so. And then at that point, you need to take more medication to keep those therapeutic levels. So I just want to give you this. These are kind of old, but you'll have to remember them because they're still used. Kind of old abbreviations for how often we give meds. So QD, Q is every, QD is every day, QID is 4 times a day, BID twice a day, TID 3 times a day. But what we tend to do more now is we tend to not use these, and we tend to just write out every day, 4 times a day, twice a day, 3 times a day, because we have an electronic medical record that makes getting those, that really clear information easy to get into our orders. Now, something that's 4 times a day means that you're going to take it 4 times basically while you're awake. So maybe breakfast, and then maybe lunch, maybe dinner, bedtime, okay? Now, if you say something needs to be given every 6 hours, it's going to be given every 6 hours, like 6 in the morning, 12, lunch 6 in the evening, and 12 midnight. So we sort of have the kind of twice a day and sort of the instructions that we give patients, right? But typically as nurses, you're not going to see something ordered as twice a day. You'll see it ordered more as every 12 hours. And if it is ordered twice a day, the pharmacy will go ahead and time it out on the medication record when they enter the medication into the system. And they will say, okay, we're going to give it at 6 and 6 a.m., 6 p.m. Okay, now we're moving on to pharmacodynamics. Now, pharmacodynamics is how a medicine changes the body, okay? So the other way around was pharmacokinetics is what the body does to the drug. It's ADME, right? It's the absorption, distribution, metabolism, excretion. It's how the body is dealing with the drug. And this is really more what we're talking about in terms of the therapeutic effect. So what the drug does to the body, right? You're nauseated and you feel terrible and you're a little green around the gills and you get a medicine and boom, you feel so much better. Okay. So we already talked about therapeutic index and range, and we'll talk about this more when we work together in class in our case studies. But again, therapeutic index or range is the measure of therapeutic safety of a drug. And drugs that have a narrow therapeutic index have much more potential to cause serious effects. A great example of this, chemotherapy or insulin. Not enough, the patient doesn't get the benefit. Too much, toxic effects, patient could die, okay? These drugs often require 2 RNs verifying them. So if you're going to give something at the bedside, you may need to get another nurse in there to come, and you're going to do, because it's got such risks associated with giving it, if you give it incorrectly, that the nurses will check, the doses and all of that. Chemotherapy is a great example of this. Chemotherapy is never just given by one nurse. It is always a process of 2 nurses sitting together, verifying, calculating doses, looking at orders, and making sure that what's being put into the patient is correct. Okay? Awesome. Let's keep going here. Sorry. Okay, cellular receptors and a drug's action. So this is really important. We're going to talk about it more, especially when we get into the autonomic nervous system, which is coming up next. The drugs act by changing or modulating an existing physiologic process, right? I mean, drugs really, for the most part, they take advantage of our existing systems, things that we already have that work, and they either maybe reverse them, or they turn them on, or they activate them. So one of the things that you're going to see a lot of as we go through drugs is certain medications will be like, it's a beta-2 receptor agonist. So we're going to talk about what that means. A receptor is basically a protein to which the medication binds to produce an effect. And these receptors exist in the body, and it's not for medications, it's really for other molecules such as hormones and neurotransmitters and growth factors. Okay, but we can make our drugs, we can dress up our little drugs in their little outfits and make them look like one of those things, a hormone or whatever, and our drug can go in and bind to that molecule. Non-receptor drugs are things that tend to just pass across the tissues or take advantage of something like osmosis. And good examples of that is like general anesthesia and osmotic diuretics. But for the most part, most of our drugs work by receptors. Morphine works by dealing with attaching to the kappa and mu receptors in your brain, as an example. Okay, so a lot of times what happens is we'll have these drugs. I don't know if anybody's ever heard of the term a beta blocker, but you may hear somebody say, yeah, I'm taking a beta blocker for my blood pressure. Well, the drug binds to a receptor and it results in some kind of therapeutic consequence. And that therapeutic consequence could be that we're inhibiting something or that we're activating something. Okay. So an agonist actually mimics the effect of something that you have inside an endogenous neurotransmitter or other kind of um, chemical that tends to cause a certain effect. So an agonist is, something that basically, triggers that tissue, that molecule, and says, "Yep, we're going to make this happen." Whereas an antagonist is a blocker. Okay. A good example is opioids. Opioids are agonists. They're opioid agonists. So morphine, fentanyl, something out on the street, right? Fentanyl. And that is attached to a receptor and it's causing this euphoric effect. If we need to reverse that, and remember, the molecules aren't just sitting there, they're like sitting and then getting into the cell, sitting, getting into the cell. So what happens is if somebody is overdosing on opioids, we can give them naloxone, better known as Narcan, and that is a blocker. It actually attaches to that same receptor, but instead of kind of opening the channels so that the drug can go in, it blocks it. It actually says, nope, sorry, you're not going to go in there. You're not going to have your intended effect. So again, we're going to talk about this more as we get to the autonomic nervous system, because the autonomic nervous system is all about receptors, mostly alpha and beta receptors in certain target organs. And if you think about it, it'll make sense when we get there. Okay, so that's really as far as I'm going to go in terms of pharmacokinetics and pharmacodynamics. However, I do want to talk just a little bit about pharmacogenomics. And we're going to have a lesson on this when you get to Nursing 356, which is the second patho-pharm. And there's a whole unit on pharmacogenomics, but this field is exploding. In fact, what I would teach you today would not be current next week. That's how fast and rapid this is changing. But essentially, now that we can sequence the human genome and we can look at every single person's, genome, we can also see where maybe they don't respond to a certain medication a certain way. Or maybe you're missing a protein somewhere that you need. So pharmacogenomics is basically taking your genomic information, the information from your genes, right, from your chromosomes, and then tailoring medications to that. And we'll talk a little bit more about that when we're in class. So anyway, like I said, this is a huge field. There's now gene therapy, there's CRISPR therapy, there's all kinds of other things that we're doing. Cancer treatments are changing radically because of some of this information. And so, yeah, it's very exciting stuff, but a little bit beyond what we're going to do for this course. So let's switch to special considerations and special populations. So obviously a pregnant mama. So we have to think about this. It's not just people who are, construction workers or whatever that break their legs. It could be a pregnant mom. And now you don't just have one patient, you have two. You have the mom and you have the baby. Or even if baby's been born, if mom's breastfeeding, i.e. lactating, then we have to think about that too, because some drugs actually pass through breast milk. So we have to be careful about the medications that we give somebody who is either A, pregnant, or B, lactating. And your drug book will have a lot of information about how safe it is for this medication, whether any research has been done on it, if there are any known severe effects, and we'll talk about this as we go forward in our slideshow here. But it's a really, really important part of care if you happen to get a pregnant patient. I always, when I was an adult nurse and we would get somebody who was pregnant and needed chemotherapy, I was always just like, oh, please don't let me have this patient today, because it's scary. It's scary to think about giving someone who's pregnant chemo, and yet we would have moms with life-threatening cancers. And so it's like, how do we, again, do that risk-benefit analysis? So lactating clients, one thing you need to know is that drugs are often able to enter breast milk. Think about it. Breast milk is like full of fat. So lipid soluble, that's great. Drugs tend to pass through, but very few drugs that get through the breast milk are harmful to the baby. So it doesn't mean that we're not concerned about it, but it is something to keep in mind. Water-soluble meds are going to have a much lower level in breast milk because, again, breast milk is so fatty. So if you have water-soluble meds, they're not going to be able to go across and get into the ducts and get into breast milk. Lipid-soluble, much easier for them. So if mom's taking like maybe something for pain that has a narcotic in it, it's possible that could get into the breast milk and affect the baby. Protein-bound drugs tend to stay in mom and not go into the breast milk. So that's good. That is a really good thing. But there are a few kind of considerations that we can think about. And, we're not going to be prescribers, right? But there are some principles that are followed when we make recommendations for what patients should take. So typically we tend to prescribe or give drugs with a shorter half-life so that they're not in the body as long, right? They're in, they do their thing, and they're done. High protein binding drugs should be used when possible because, again, if the drug binds with proteins, it's less likely to be expressed in the breast milk. Herbal and dietary things, supplements should be avoided unless the woman is in, agreement with her healthcare provider who follows her and her baby. So herbal and dietary things, you can't just take any herbal supplement when you're pregnant without consequence. And then use non-pharmacologic alternatives whenever possible to decrease drug use in a pregnant or lactating mom. Things like music or massage or heat or cold. And probably the most important thing on this slide in terms of your interaction with lactating clients is to remember that you are going to give medications after breastfeeding rather than before. If you give medications before breastfeeding, right, then while that baby is nursing, mom's processing the drug, the body's processing the drug, and it's possible that it's going to be in her breast milk. Versus if mom goes ahead and nurses the baby, now we've got probably, usually there's, at least a couple of hours of a break before baby nurses again. So then you go ahead and give the med kind of after that. So you want the drug concentrations to be as low as possible. So the key thing here is give medications after breastfeeding to reduce exposure to the infant. Teratogen. A teratogen is a substance, organism, or physical agent to which an embryo or fetus is exposed that produces a permanent abnormality in structure or function. I will give you a great example. Radiation is a teratogen. That's why we ask people if they're pregnant when they go in to have x-rays, and that oftentimes lead aprons are put over the uterus and ovaries. But we know that radiation can even be bad for adults, right? So if we have excessive radiation exposure, you're more at risk for cancer. But teratogen really refers to what happens to the fetus or the embryo. So a teratogen often is, so we'll call some drugs teratogens. And they can cause growth retardation, they can cause fetal death, they can cause malformation. The children that you see in this picture, their moms took, this is from the 50s, their moms took thalidomide, which was a medication thought to help deal with nausea during pregnancy. But unfortunately, thalidomide is a teratogen, and it has an effect during limb formation. And that's around the time moms were taking it when they were first pregnant and they were having a lot of nausea. So you don't see many children like this today, but there was a whole generation of children that had limb anomalies from thalidomide. It also speaks to all of our processes now for getting drugs approved and why we do or don't do studies in pregnant women and that kind of thing. That's a whole other issue. Examples of teratogens are chemotherapy. Not all chemotherapies, but there are some that are very harmful to a growing fetus or embryo. And the other one is Retin-A. And if anyone's ever taken Retin-A, you basically have to, sign your life away that you're going to either not have sex, or if you do, you're going to use like 27 forms of birth control, because Retin-A is a known teratogen and can cause many birth defects. Okay, pregnancy drug categories. Again, there's several categories in here, but there's some changing thought on this. And I'll be interested to see what your drug book says about this. I haven't looked at it specifically for it, but there used to be kind of different categories. Like this one is safe during certain, in the first or 3 months, or this one's safe in the last 3 months, or whatever. But I think what they're trying to do is move away from that, because it gives people maybe a false sense of security that a drug is okay. And really the goal is to not give moms who are pregnant, any more medications than they need to get. And we'll talk about that a little bit too, because frankly, if I'm going to take a drug while I'm pregnant, let's say I have a wicked cold and I'm at a point where I can take some cold medicine, you want to take enough for it to be effective. Otherwise, why take it at all, right? If you're going to not take enough for it to work, then you might as well not take it. So we have to think about that. So here's some things that you could look up to see what categories they are. Let's go talk a little bit about kids as well. So medication in children. You have to think about giving them in a developmentally appropriate method, right? You're not going to go to a 2-year-old and give meds the same way to a 2-year-old as you are to an 18-year-old. An 18-year-old, you can talk, you can reason, you can give a rationale, you can negotiate maybe a time or what they want to take it with. Not with a 2-year-old, right? So doses are usually weight-based. Mgs per kg or micrograms per kg, but it's weight-based. And if you think about that, that's because in adults typically give standard doses. Like the standard dose for this antibiotic is, 350 milligrams. Well, that's fine for adults, but for kids who could be anywhere from days old to many years old, their organs are in different, levels of maturity. And so we have to be really careful about that. One thing to remember about children is their liver and kidneys are immature, and that prolongs the duration of action, right? Remember, liver is metabolism, kidneys are excretion. If they're immature and not quite working, at their capacity yet, then drugs are going to stay in a little bit longer. The other thing is that babies, like older people, they don't have as tight of a blood-brain barrier. It's not well developed yet. Same for older adults. Theirs tends to get looser with age. So you can almost take older adults, the elderly, and children or infants, and there's many similarities in how they're going to respond to these medications. On the older adult side, it's because their organs are kind of shot. On the pediatric side, it's because the organs are not fully functioning yet and immature. One thing I do want to tell you is 75% of the drugs that are used in children contain no specific dosing info from the manufacturer. We just don't account for changes in physiology and biochemistry and that are in kids. And we have an issue with doing studies in children. But at the same time, if we don't do studies and we're giving children medications and we're using adults as the model, right, and we're just sort of decreasing the dose, we're really just guessing. So there are a lot of incentives that have been offered by Congress to promote clinical evaluation of drugs in children safely, right? So I said in here we need to do this with COVID vaccine. Well, just recently, within the last 6 months, right, it has been approved for children, and it was to the age of 5. Now we're looking at children younger than that and whether they can mount a response. So things are always changing, you guys. Kind of fun. Okay, and then older adults. Aren't they cute? They're so cute. I don't know them, but they're very cute. So when we're giving medications to older adults, we have to think about the fact that there's an increased number of chronic diseases and health problems. Remember, they have that issue with polypharmacy. They have degeneration of their organ systems, so things don't work as well. Kidneys aren't going to excrete as well. Livers aren't going to metabolize as well. They are at an increased risk for drug interactions and side effects. And that's a combination of things. It's their organs, but it's also, again, polypharmacy and maybe their own cognitive abilities. The other thing is that as you get older, you're much more susceptible to having a severe illness. And so, something that is relatively mild in someone who's young and healthy can be, devastating or fatal in an older person. They just don't have the immune system and the reserves to deal with things the same. There can be compliance issues. It's interesting. I think as we see different generations age, this may change, but I would say current generation of, the elderly comes from a kind of, if the doctor says do it, you do it. So I think they want to be compliant. Of course, you're going to find people who are like, I don't take medicine, I don't believe in it, blah, blah, blah. And that's fine too. You just have to deal with that. But I do think that it just gets more complicated for elders to take medications. So again, provide opportunities for independence and dignity. People who are getting older, they know that they're not able to do things as much, and it's hard to accept that fact. So they may have trouble opening packages or bottles. What things can we do to try to make those easier? Can we, if they don't have little kids in their home, maybe they don't need a child-proof top on their meds. And so those are very difficult for the elderly to get off. Maybe they need a calendar with their meds written on it. Maybe they need some other reminder system. Pill boxes, instructions, reminders on mirrors, those kinds of things. So, and then we have to remember that as adults get older, we still need to be very proactive in our care of them in terms of preventative care. So they're good candidates for things like flu and pneumonia vaccines because those illnesses can be fatal in that population. All right, guys, so we're starting to jump in. From here, we're going to go to actual meds. And I look forward to talking more about this with you in class. Have a great day.